of Wysonic Dandelion College. Wysonic Dandelion College is a free online platform for the purpose of sharing the cutting-edge know-how and insights of POC ultrasound applications with global professionals and medical practitioners. Today, we are much honored to invite Dr. Rüdiger Einholz and Dr. Wolfgang Buchuster from AEN Group in Germany as our webinar speaker to share their valuable experiences of beyond stethoscope and clinic exam, the role of bedside ultrasound in the clinic workup of acute shortness of breath. Hello, Dr. Einholz and Dr. Buchuster. Dr. Einholz, he is a consultant anesthetist and partner of Medical Care Center Medicine GBR in Stuttgart. And Dr. Buchuster, he is head of Department of Anesthesiology, Intensive Care, Pain Therapy at Christine Hospital of Wuna. Both of them are world-known speaker of ESRA, the European Society of Regional Anesthesia and Pain Therapy. So today's webinar will be divided into two major sessions. The first session is lecture by Dr. Einholz and Dr. Buchuster. The second session is Q&A part. Welcome all of you to raise your questions and further communicate with our speaker at the whole webinar. Let's welcome Dr. Einholz and Dr. Buchuster. Yes, let's start.
Yes, we will. Thank you very much, Jessie. Thanks to the audience. We're pleased to join the webinar, to lead the webinar, and to give our experiences to you and discuss our experiences with you. So, as you said, and with your charming dialect, Una.
Una Hospital.
Is relatively unknown in Germany. I come from the south of Germany, where actually Rüdiger is working. So please, Rüdiger, you're here?
Yes, I'm working near Stuttgart, or in Stuttgart basically, and all around Stuttgart. And so we've got a little private anesthesia practice down there, taking care of roughly 30 different surgery places. And so we focus nowadays on the outpatient work, and Wolf is more focused on the inpatient care. So, and we actually got to know many years back and discovered our passion for the ultrasound. And so this is why we try to develop materials to teach ultrasound. And so today's session is more like a didactic session. It's not meant like a scientific approach on like to quote many studies, but we will try to explain, to give an introduction into how ultrasound can assist us and help us in doing the workup of patients with acute shortness of breath. And the good thing of the pandemic is that we are having this webinar now. So we're trying to bring all of us a little closer together by this, and we try to contribute in this. The less good thing is that we don't see you really, and that we can't talk to you directly. So we have no idea who is participating. So maybe we've got many experts under you, maybe we've got beginners. And so we decided to give an overview to have like good hints for beginners, and to have certainly also some tips and tricks for the experts under you.
But
so
mainly,
Wolf, how about conflicts of interests?
So in our opinion, we do not have conflicts of interest because yes, we're doing courses, yes, we're writing books, and yes, we're having public dialogues about ultrasound in lessons for some enterprises. But in our opinion, we transfer the knowledge, and in our opinion, this is not a conflict of interest. The full webinar, give us our question in the Q&A section, so we don't have to collect them to one time point and hurry through. That'd be much better. Thank you.
Okay, so what's probably a bit unusual to some of you is that we are holding this webinar with two speakers. We are actually we're not sitting on one desk. So so Wolf is in Unna, I'm in Stuttgart, and we are trying to make little interplay with who is talking and who's answering questions. So let's see how we go, and we try this method to make the webinar kind of entertaining for you and also not so tiring. So especially those who are in the Far East, from our standpoint, they they've had a hard week and it's Friday night now. So we are trying to entertain you that you don't fall asleep. Okay, so let's start. So what will be our session? So we would like to point out that point of care ultrasound, bedside ultrasound, is a very, very good tool to have if you have patients with acute shortness of breath who are in respiratory distress. And of course, we still need the clinical examination. We still need the history, whether the patient is a trauma patient, whether the patient is on an internal ward, so it looks more like a cardiac problem, or whether the patient comes right from the operating room with maybe an interscalene catheter. So we still need the clinical examination, our clinical view on how to assess patients. We still also may need the stethoscope, but with the stethoscope, our problem was that we tried to hear inside the patient, and the noise that gives us information on what we hear is being generated inside the patient. And of course, what we hear is very much dependent on the noises wherever we do the examination. So sometimes we can't hear nothing because we're sitting in a helicopter. So in this case, we prefer to use far more advanced technology like ultrasound that replaces the stethoscope. And now we are putting onto the patient our source of noise from the outside and getting back hopefully wonderful images. So Wolf, what do we see here as an introduction?
Well, in our introduction slide, we have different entities. So mainly lung ultrasound was not the primary thing to examine. The stethoscope was first because people and doctors thought that artifacts are just bad and not for diagnosing, but for all the other diagnosing procedures we do, this might be true. But lung ultrasound lives from interpretation of the specific artifacts. And we go through 5 different entities like B lines, like actually the diaphragm sign, diaphragm. Everybody's talking about you see the diaphragm, but you don't see the diaphragm, you see the pleura. And in this picture, consolidation. So most of the time, we're talking about artifacts that are leading to diagnosis. And this is the most important message. So if we go to the next slide, this is about how people or medical doctors in former times said, oh, you can't diagnose because if you take in a porcine model of lung ultrasound and you do inflation by putting it to a ventilator, you inflate. So all you got, because under the visceral pleura, you just have the intra-alveolar air inside. That is 100% barrier for ultrasound. So all the energy is reflected back and you just have in a multiple line pictures with no possibility to diagnose. And that's the reason why in former times, doctors said lung ultrasound may not be possible.
And to be more precise, radiologists said this, and the medic quite a bit. So if you look at this wonderful picture, you see a surface, a very, very even surface of a little lake. And you can see a lot of things on the surface, but you cannot see the ground. So you can see something on the surface, but you can't look through it. And this seems to be a little bit the issue with pleural ultrasound, that you can look onto the pleural surface, but it's difficult to look inside, given that it is a healthy lung. But we can see actually changes on the surface. So imagine on this lake, there's a little wind blowing all over it. Then all of a sudden, it looks like this. So from the perfect mirror image, like here, you get a little bit of a non-focused or of an alteration of this mirror image. And so you see something on the surface that can tell you something about what is underneath, but still you cannot see the ground. And this is important in understanding that if we scan a healthy individual, we can't really see something inside the lung, but we can see something on the surface, a lot of mirror images that are being transposed in the lower part under the pleural line in our ultrasound image. So how much of the pleura is actually accessible with ultrasound, Wolf?
Well, one says that about 70% of the pleura might be to be inspected, but in fact, that's for the internal medicine people that have self-briefing patients sitting on the bed, because they can put their arms over the head so the scapula rotates. They can use some tools of motion that more of the pleura will be available than for us in the operation theater or the intensive care unit. Because our patients, they are lying supine, they have cables, they have tapes and drapes. So we think about 50–60% of the pleura would be possible to be inspected by intensivists. So, and this might be also possible with the linear probe, and also not just for the diaphragm, but also for the pleura with a convex probe. Just let's have a look at this special image. And as I said before, when you look through the chest wall, or the abdomen, from the abdomen to the chest wall, you see the bright light of the diaphragm. That's not diaphragm musculature, but that's the impedance signal hyperechoic of the diaphragm. So this is also part of the pleura we view.
And we will come back to the impedance definition in a minute. So we will quickly go to some ultrasound basics, because for some of you it might not be so common. So we're talking about certain terms and definitions, and we just quickly go over it. For the experts, I know you, it's more a matter of how to explain things, as you probably do yourself. So of course we need the B mode, the brightness mode. What is brightness mode, Wolf?
Well, the B mode is the two-dimensional diagnosing with ultrasound. So you align the probe and you have a kind of diagram with a linear probe. You have a rectangular visualization, and with the abdominal probe it is a little bit modified, but it's a 2D image. And the third dimension, that's the movement of your hand, that you have a scanning mode that is dynamic over the body. So you, in your own head, the two-dimension procedure of ultrasound can be put in a three-dimensional image in your head. But the B mode is just the scanning picture on the monitor.
And basically all the machines start in the brightness mode, and it's called brightness because, of course, unfortunately, most of our pictures are not colored. So we get different grayscale, so different brightnesses. And of course, in order to optimize our ultrasound image, we also can.
How quick is the sound conduction in air? Because now you visualized how it is in human tissue. It's about 1,540 meters per second. What about the velocity in air?
Well, this is much slower. And the general idea in physics is that the less dense the media is, the slower the sound will travel. So air is not very dense, so the sound is relatively slow with 330 meters per second. And so the average in human tissue is about 5 times as fast. And the denser the tissue gets, like in bone, the faster the velocity will be. Like in bone, it's 3,000 to 5,000 meters per second. But the ultrasound machines, normally they calculate with an average of the spread of sound of 1,540 meters per second. And so in air, it is much slower. And now imagine you've got a bit of sound traveling through the chest wall with the set speed of 1,540 meters per second. And then this sound energy hits the pleura. Behind the pleura, we have air. And the velocity is only 1/5 of the velocity in the chest wall. So most of the energy is going to be reflected. And so this is important to keep in mind when we talk about some artifacts later on. Then there is one more important thing, the acoustic resistance impedance. We'll have some slides on that in a minute. And also we need the M mode, the motion mode. We will explain with slides. And at the end, we have a lot of artifacts that are very useful for us for the interpretation of what is below the surface. As we said before, we can't really look inside the lungs, given that the lung is healthy. So what is acoustic resistance or impedance, Wolf?
Well, that's not easy to explain, but we do it in easy words. So probably medium A is chest wall, or let's say that's musculature. And medium B, for the first thinking, might be fat. So if the sound from the probe reaches the frontier or the barrier from A to B, there's some energy traveling through medium B also, but most of the energy is going back to the probe and doing a bright signal on the line that is between medium A, medium B, maybe a fascia. And if you think that medium A is a chest wall and medium B might be the pleura, or the intraalveolar air. So there will be no traveling of ultrasound energy in medium B, and nearly all energy is just transported back to medium A. So that's a frontier, a barrier, and you don't look at typically a pattern of tissue in medium B, but just a reflection mode shows us artifacts as mirror artifacts. We come in later on to that specific topic. So but Rüdiger, I have a question to you. So with the B mode, we have a lot of crystals, electric crystals working to generate beam and sound. They are working together as apertures. That's B mode. And what about M mode? What is M mode?
Well, the motion mode is one specific mode of action of the ultrasound machine that gives one group of crystals a special job. And this one group is called the aperture. So let's say 8 different crystals are actually connected together electronically. And whereas all the rest are creating the B mode image, like here in a heart ultrasound, there is one group that, like, for instance, this one here, and this group is activated and the rest of the group is deactivated. And all the signals from this particular vertical line is the ECG-like pattern. We get all the motions that are on this particular vertical line. So every white dot that moves will get curvy, and every black dot, for instance, that's not going to move will result in a black line. And now we used to understand M-mode as a very specialized working models of the machine that only cardiologists use, but no, it's different now. We also can use it. And what for, Wolf? What do we use the M-mode for?
Well, the profound pattern we use M-mode for on the chest wall, we're coming on later on. But also, if you go please to the next picture, we can use it for in acute dyspnea or shortness of breath. You diagnose also the functioning of the diaphragm. Because not very seldomly, if you put in an interscalene catheter, or you have a trauma patient, or you have an internal medicine patient, very sick and shortness of breath, and he has a cancer, so a mediastinal cancer that might affect the vagus nerve supplying the diaphragm, and so might be you have to check the function of the diaphragm to assume if it's just musculature, pneumonia, consolidation, or even diaphragm function that leads to a shortening of breath. And that's very easy to diagnose. And here with the M-mode, through the diaphragm, or the pleural sign of the diaphragm, as Rüdiger showed. And if you put it on an ordinate and a system running over the time, you see the movement of the diaphragm going abdominally. You have some peak or on top. And if the patient just does a short sniff, so a very short inspiration, it is better shown most of the times in a picture than a weak normal breath. So you can image it really perfectly, and you save the picture, and you can assure that the diaphragm is not the reason for the shortness of breath in the patient.
And what you see here, for instance, is when the patient breathes in deeply, for those of you who know it already, there is what we call the lung is actually merging underneath the probe. And this is why you get an image artifact here, which is called the dirty curtain, because you don't see anything anymore. And this is actually what we want. So we want the lung to be filled with air, and with inspiration, it will actually move underneath the probe. So you've got the dirty curtain. And if you image this in M-mode, you see it like this looks like little mountains, and this looks like more like a volcano erupting. And this is the dirty curtain coming into the image. And whenever we see the dirty curtain coming in, we know that there cannot be a large amount of effusion into the pleural cavity. So the dirty curtain is our friend. Okay, so if we have a patient like after surgery, after shoulder surgery in recovery room, and the saturation drops, and it is not too much opioids remaining, if it's not too much muscle relaxant remaining, we may have a look on the diaphragm. And if you see the B-mode image, the patient is asked to do very deep inspirations, but the only thing that happens is that it's like a wobbly picture of the diaphragm here, and this results in a rather flat line in the M-mode. So this is a proof of diaphragmatic hemiparesis after interscalene block with catheter. And so what do? Of course, in this lady here, we didn't even start the catheter, so we just stopped it and waited until the diaphragm was back to normal. And then we only used the catheter, well, if you can't deal with the pain in any other way. But she is, of course, on the normal ward, she is in jeopardy of getting shortness of breath unmonitored. So of course, it's only a question of a few minutes to look on the diaphragm, and then you know what is the.
Usually we do have a supine lying patient, and most or many times we're looking for pneumothoraxes, and the air that should be detected outside of the lung will be at the region just 10 centimeters peristernal. And so the most important window is the direct peristernal window to both sides. So if you look at the chest wall right here, you have the subcutaneous fat tissue, you have the pectoralis muscle, and now give me help, Rüdiger,
the intercostal muscles and the ribs.
Intercostal, yeah. The intercostal musculature, you can say it's the external intercostal and the internal intercostal. And below, you have the thoracal fascia and the pleura parietalis that are fixed on each other end to the tissues. So, and these pleura parietalis is doing the perfect mirror image. Error image because it's artifacts, the mirror image of the chest wall below the picture.
So let's have a look what we see. So you might have heard from a term that is called the A lines. And A lines are just artifacts that develop as mirror artifacts. So you see the skin with S and the P like the pleura. The pleura is the brightest section in this image because this is the mirror plane where most of the energy gets reflected right away by hitting it only one time. So the sound travels through the pleura with 1540 meters per second, hits it and gets reflected. And on the way back to the probe, there is another change of impedance between the skin and the probe itself. So some of the energy doesn't get into the probe right away, but it's being reflected back to the pleura and then goes back to the probe. And this results in a doubled travel time of the sound. So the sound travels from the probe to the pleura, back to the probe. And once it gets into the probe, it will actually result in an image like the pleura. But the parts of the sound that are being reflected here, they travel back to the pleura again. So the travel time is doubled. And the machine thinks, oh, okay, the reflector must be deeper. So you get another line here. And so the definition of A lines is a mirror image where the skin to pleura distance is being depicted inside the lung. And of course, this is not real. This is just artifact. And you also can have this with a curved probe. You see it here. The pleura is here. The real pleura ribs are here. And now we've got one A line here, another one here. And we can hence have several A lines being depicted. And our opinion is it is important to know that also in literature we have A lines, but for us it's not so important for a diagnostic process. So of course, if we see A lines, it doesn't say too much to us. But of course, A lines would not be present here in case we've got a big effusion. So what else do we have on artifacts, Wolf?
Well, the most important artifacts are the comet tail artifacts. They were primarily shown by Daniel Lichtenstein from Paris. That is many years ago already. So how are they being created? So as I mentioned already before, the parietal pleura is just stick to the chest wall. The visceral pleura is adhesive on the lung surface, and you got probably not a straight line or a straight plane tissue, but you have some septors like interlobular septa, where the typical motion fluid between the two pleura fascias can collect. And in interlobular septula, there are also some lymphatic where drop of fluid works like an acoustic lens. So all the energy is reflected like directly and in a reverberation mode, that the sound that's going back to the probe and detected by the probe shows some kind of artifact picture until the reverberation energy is gone for the scanning moment. So it starts with a bright line, and as you see in the picture here, it's not just a straight line downwards, but you mention from one point of the visceral pleura, you have about 3 lines in a different angle. And this is because ultrasound beam is not just straight running through, but in every action of the piezo crystals or the apertures that are working together, you have a straight beam down and also an angulated one to 10, 20, or 30 degrees to both sides. And that's the compound imaging or cross beam, as was, or as different manufacturers say. And this is indicating, so every comet tail artifact that can be imagined on a picture that is moving with inspiration up and down, or even also with the systole or diastolic movement of the heart in the thorax, says that no pneumothorax is possible in this position to the actual moment.
Okay, thank you. Let's go on to B-lines. B-lines are the big brothers of the comet tail artifacts because they result in just bigger amount of fluid collections in the pleural space. So as Wolf explained, the sound energy is trapped inside fluid collections and goes back and forth so many times that the sound travel time is being longer. And this is why the ultrasound machine thinks, okay, again, the reflector must be deeper. And you can get this, of course, with linear probes like here, or with curved arrays like here. And the amount of B-lines we see, and B-lines actually, they go over the whole ultrasound image. And the amount of B-lines somewhat is a sign for the fluid in the lungs. So congestive heart failure, very often you will see an increased amount of B-lines. And as we said before, this can be one reason for acute shortness of breath.
So a question from me to you, Rüdiger. So B-lines, very often, if you have more than 3 B-lines, people or doctors say, oh, that's a cardiac edema. So there might be other reasons for B-lines than cardiac edema, don't we?
Yes, of course, they are. Going back to the physics, we get B-lines whenever there is enough fluid collections. And this fluid collection is only a small amount of fluid collection. So it's not like in pleural effusion. And of course, you can have other pulmonary diseases, like also in consolidation, when there is an infiltrate inside the tissue, you can have fluid collection. And of course, B-lines are possible, but those B-lines may not start from the pleural line. This is a little bit of a difference. And in the consensus conferences, people are actually arguing that ordinary B-lines should be beginning at the pleural line, but there is some discussion on this.
Yes, okay. And the multiple B-lines should not be just at one point. It should be over both lungs. That's important. That might be, they might appear in lung contusion, in acute pneumonia at the actual part of the lung where it arises, or in pleuritis, and in many rheumatic diseases. That's to be known. So what about diagnosing with a curved probe, Rüdiger?
Yeah, same thing. So the curved probe has the advantage that we have a sort of wide angle view. So as here you see the rib shadows of 2 to 3 ribs, and then you can actually assess several intercostal space at once. And you use the zoom window in the chest wall, like here, and then you enlarge the picture. You have a very, very quiet picture. So every gray dot remains a gray dot, every white dot likewise. But if you now set the zoom area below the pleural line, you've got a very, very unsteady image. So it is what you can call a flickering image. So every gray and black dots changes in the grayscale. And this is very typical for coming back to the photographs of the lake we had in the beginning. So when you look at the chest wall, it's a very, very calm picture, like the surface on the first photograph. But if you're now coming underneath the pleura, this is what happens underneath, secondary to the sliding of the lungs. So both sheath of the pleura are moving against each other, and then you've got the little fluid collections between, and this results in this flickering image below the pleura. And whenever you see this, there can't be pneumothorax, right? So, and if we look at this on the M mode, as we explained before, so we have one aperture being activated, and now we've got like, it's B mode. So we've got like, we've got one comet tail artifact now, and you see that this is exactly the heart rate. So this is called the lung pulse. And the lung pulse normally only is visible inside the lung until the pleura. So it is not visible inside the chest wall. So when you put a color power Doppler on it, you only see it underneath the pleura and not in the chest wall. And likewise, if you put the M mode in it, you only can see this pulsating thing underneath the pleura. The pleural line is the brightest line here, and you see parallel lines here as being the chest wall, and you see the sandy image here, but you see some columns here. Do you see this? And this is part of the heartbeat, the differences in the pressure generated by the heart is being transmitted to the chest wall, but only to the border of the pleura. Right? So this is the lung pulse. And again, this transmission of the pressure changes of the heart only can happen when there's no pneumothorax. So whenever you see lung pulse, can't be a pneumothorax. Pneumothorax is ruled out then.
So let's come again to all the artifacts again, and let's resume a little bit. So in normal respiratory function of the pleura, if you align the probe and in the B mode picture, you see mirror artifact. The mirror line is the pleural line. The mirror line, the actual mirror line is the parietal pleura. The visceral pleura that slides does the flickering of the mirror image. Just imagine this for M mode. Then you look for lung sliding. Look for little hyperechoic points that are running up and down with inspiration and expiratory function of the lung. If you don't see it in the normal picture, peristernal between the ribs, just look under the cartilaginous ribs, because you can look through. They have a lot amount of water, the cartilage of the ribs, and it also works like about a lens. And under it, you can really see the pleural line with a sliding movement, and sometimes much better than in the free field between the ribs. So you look again for the artifact of the A line, but that's not a very, very good, valuable diagnosing parameter. A line one says it's if the A lines are erased by B lines, you see no A lines because the B lines are prominent, you have to think about a cardiac edema or some diseases that produce the B situation, like after a deceleration trauma and a lung trauma, or in a pleuritis, in a regional pleuritis, or in a regional pneumonia. There may be the appearance of B lines too, just regionally. If the patient does not ventilate, so he just stops but has heart function, you see the lung pulse that Rüdiger showed you in the last slide. Just say to the patient, hold your breath, and you see the little hyperechoic points or the comet tail artifacts just going with the function of systole and diastole of the heart. So that's the motion artifact, and you also can visualize motion in ultrasound in color Doppler or in color Doppler. And we come in again to that issue later on. So the M mode, let's go to M mode again. Please go to, to the next information point. The M mode leads to a picture that actually we can say where you have the barcode sign of the chest wall in the M mode picture, that's kind of stratosphere. So that's the sky picture. If you have the pleura as the mirror line and underneath with a working visceral pleura not having a pneumothorax, the bright mirror image is disturbed by a sandy pictures because of the flickering, and the flickering in the M mode, whereas Rüdiger says, does statically or permanently changing of the gray values. So that's not just a dark dot stays a dark dot, a white dot stays as a white dot. And this is creating the sandy picture underneath the pleura. And we say in the literature or actually under doctors very prominently, you hear the seashore sign for that appearance.
And seashore sign is a normal finding. So just to repeat it quickly, we have the chest wall window and the M mode is in there like this. You see the lung sliding, and now you put it in M mode and you see the sand, you see the wall, and you see the sky. And this is the seashore sign. And you might keep it in mind much better if you remember this. So this is part of the idea the ones had when they discovered it. Okay, so this is normal finding. Seashore sign is good. So what else do we have? Let's go to a clinical case. So we have a patient and we have an M mode picture, and he has been intubated and the saturation drops. So what is it? Is the FiO2 too low? What is the problem? And let's say you were in an aircraft doing patient retrievals or in a helicopter, so you can't use your stethoscope. Of course, normally you would just listen onto the chest. In this case, you just put your probe on, and what you see on the right side is basically a seashore sign. So as we said before, this is normal finding. So that's normal. So if you go on the other side, what you see here is again seashore sign in a way, but it is also with lung pulse. So two normal findings. So what's wrong with it? The saturation still drops. So taking into consideration like the idea on how lung pulse comes about, it must be that there is no lung sliding, because the pressure changes of the heart are being transmitted to the pleura, creating the lung pulse. So there is no lung sliding. Hence, this patient is intubated too deeply. So the left side is not ventilated. There is no pneumothorax, but it's not ventilated. So tube out and the problem is solved. Okay. So let's talk about pneumothorax. So the artifacts are somewhat different now because the mirror artifact is in B mode. It is not this unsteady flickering image anymore underneath the pleural line. So there is a perfect mirror artifact, so image of the chest wall below the surface of the pleura, below the mirror plane. So no lung sliding. You have no cometails or B lines because there are no fluid collections as such as they could create B lines. And in the M mode, you have got this perfect mirror image also underneath the pleura. So we are getting to the barcode or stratosphere sign. And again, put in other images, we've got this M mode image here as normal seashore sign. And if you look at the two B mode images here, you've got on one side, you see like the normal lung sliding, and on the other side, you don't see it. So it is not there. Lung sliding is missing. And if you go into M mode, you see this. So you have seashore sign on the one side and stratosphere sign on the other. So the sand is missing because the disturbance of the lung sliding is missing. So this is what you get. And so whenever you find this, you may have pneumothorax. So it is like a barcode, like a stratosphere all over the M-mode image, like this. Okay, so Wolf, why do we want to use more ultrasound in patients with acute shortness of breath and pneumothorax?
Well, the answer is because it has a much better sensitivity. So let's look at this very old study. They had in a trauma center about 135 patients having all the diagnostic you would like to have a complete diagnostic. What one thought that is a complete diagnostic. So you always do the X-ray. Most of the times you do by a harmfully trauma patient chest CT. Everyone had a lung ultrasound. And if you look in the next information points for the sensitivity, when you're doing just a parasternal, as we showed you, a parasternal ultrasound of both lungs in 68% sensitivity. So you find the diagnosis of pneumothorax in the patient is much higher than in the radiologic procedure of a two-dimensional picture, because all the partial pneumothoraxes, as you see in that CT scan here, are not leading to a diagnosis of partial pneumothorax, because in a two-dimensional conventional radiologic picture, the lung may be completely over the hemithorax, and you miss the diagnosis of a pathology. And it's about a 50% better sensitivity. So you're the better doctor, you have better diagnosis, or probably quicker therapies. So let's look at the next picture. So please, the next slide. One may ask, well, with ultrasound, you're really good diagnoser, but Rüdiger, what about the diagnosing of the size of the pneumothorax?
Yeah, that's actually an issue, because if you've got only like a very small partial pneumothorax with a little bit of air collection between the two pleural sheaths, the acoustic phenomenon is the same as if it was a big pneumothorax. So looking at the M mode, you get the barcode sign or the stratosphere sign right away if it's only like 1 millimeter of air collection between the two sheaths. So it is the same image like having 10 centimeters because there is no lung sliding. And so with only just one scanning window, you can't tell anything about the size of the pneumothorax. And because of this, you need to bring your probe in motion. So you have to slide it more laterally in the same intercostal space, for instance. And then all over a sudden, you may find that you get a normal finding like here. So you slide the probe from peristernal position more laterally. You have the lung will actually get in contact to the chest wall. And with expiration, it will lose the contact. And so by this, you can actually say something about the size of the pneumothorax. And this changing of normal finding and pathologic finding is named the lung point. And of course, you can see it also in the ML. So this is normal seashore sign. This is full pneumothorax. And with inspiration, you may find this. So it changes from pneumothorax to seashore sign. And this is the lung point, which has the highest specificity in diagnosing pneumothorax. And now let's go to clinical case. So someone comes in with shortness of breath, and you just look on the B mode images, and you see on this side here that there is some normal lung sliding here. You see the unsteady image, B mode image here. And on that side, you see that there's a lot of motion. But if you look on the pleural line, there's no lung sliding like it is here. And if you look at this on the M mode, you will find a normal seashore sign here. That's normal on the right body side, so no pneumothorax there. But here you find the barcode sign, the stratosphere sign. So there is some pneumothorax here. And Wolf, why does this area kind of looks like lung pulse? So there is some sort of column going through the whole chest wall. Could this be lung pulse? And could it be a pneumothorax ruled out in shortness of breath of other reasons?
And that's a very, very, very good question, because you have to look profoundly at the picture. If you look profoundly, you see underneath the pleura really the sign like the start of the motion of the heart in a systole and a diastole, with two lines going completely through. But if you look at the chest wall, you see the both lines also going through the chest wall. And that means that if you do have a patient with a dyspnea, and with a dyspnea who is fighting for oxygenation, he's using his additional musculature of the thorax wall to inspirate and to expirate heavily. And this does also for if you have a pneumothorax on this side, really, and he uses the other side of the lung for extreme motion of the chest wall, you have a pneumothorax picture on this side with continuing lines in the chest wall indicating that he is in heavily dyspnea. But if you look at the moving picture, you see that there's originally no movement of the lung in B mode. In M mode, you have no sandy space, and the lines are completely going through underneath and over the pleural line through the chest wall. And that's just a visualization of the muscular picture of dyspnea breathing of the patient.
Okay, so we have to keep in mind that lung pulse only under normal conditions goes to the pleural line and not into the chest wall, unless with like septic patients. Sometimes you can see the pulsations on ICU just from looking from the outside, but this is an exception. So normally the lung pulse stops on the pleural line. And if you scan yourself, you may try this out. You can just use the normal scanning window, peristernal. And if you then put the M mode in and you do some cuffing exercises, you will see that there are motion artifacts through the whole chest wall. So this is not lung pulse, of course, this is just cuffing and motion of the chest wall. Okay, so let's try to have a quick look on another case, and then looking on the timeline with a few more minutes before we actually can start the Q&A part. And please, if you haven't done already, collect your questions and write them into the Q&A section of this meeting so that we can later on come into a nice discussion. Well, the patient clinically, he's a young, healthy individual. Like under rest, he wouldn't actually have shortness of breath. So there is a fracture, there is nothing on the chest X-ray, and so how about ultrasound? So we've got the right body side here, the left body side here, and so we look onto the B-mode image and we see normal lung sliding here. And on the other side, we don't see it. We see some motion from inspiration and expiration. So the pleura is kind of being bulged outside and inside by the chest pressure changes, but there is no lung sliding. So looks like pneumothorax. So we put M-mode in, and M-mode is a bit of a difficult thing because the quality of the image depends very much on the insonation angle. So here you can see sort of a seashore sign, and here you can see sort of a barcode sign. However, it's not good image quality. So you have to work with your probe to get it visualized much better, like here. So now you've got a very clear sandy picture, normal finding on the left body side, and pneumothorax on the right body side. And of course, we can also use the other modes of the machine to visualize it, like the power Doppler, or you can even use the normal Doppler and adjust the flow velocity to very low flows, and you get basically the same. So we've got lung panels in color power Doppler below the pleural line. And if we do the same thing, same machine settings on the other side, nothing happens. So there must be pneumothorax. So no transmission of the pressure changes through the lung, through the two pleural sheath to the pleural line. So now what you see here, and this might be difficult to see, maybe the transmission over Zoom is not so good, but sometimes you see normal lung sliding, sometimes like now you don't see it. And now all of a sudden it comes back. So this is in B mode image, this is lung point. And this is, as you can see here, you see a rib here, and you also can see the pleura underneath the rib. This means this is cartilage. So this must be in very, very near vicinity to the sternum. So it's, and you can see the lung point in this position. So this pneumothorax is only a very small one. And if you look at this in M mode, you see the typical lung point here. And if you then go, or like here, it's just a different position. And so if you look at the chest CT scan then, you see that there is a minor pneumothorax here, and which was not seen on the X-ray. But you see it with ultrasound. You are much quicker with ultrasound because you have it bedside, you just put the probe on and you can have the diagnosis. The CT scan takes a while, the X-ray takes a while because you need to get the order in, you need to come, the radiology assistants with the machine to the bed, unless you are in emergency room anywhere, anyway where you have it available. But then it takes more time, and with ultrasound, you can get the diagnosis right away. But Wolf, if you have this diagnosis, let's say you are in the emergency room, you put your probe on, and in 2 minutes you have got the diagnosis, okay, it's a trauma patient, he has pneumothorax on one side, and it's not very big because you've found the lung point right here, okay? Because if it was a big pneumothorax, you can't find the lung point because at no position there is a normal finding. Okay, back into this case. You are in the emergency room, you find pneumothorax sign. Do you then do a chest X-ray? What is your clinical procedure? Do you then do another exam like 1 hour later? What do you do?
So that's a very, very good question. And we, in our experience, with the patients that had abdominal operation and having esophageal surgery. And so you have air, so you produced by an abdominal operation near the diaphragm, a pneumothorax on one side. We usually, before closing, expand it. And if you look afterwards to a new appearance, clinically reshaping patient in the emergency room, you diagnose in about 90% a small pneumothorax. So what you have collect is the data of the patient. If he has just no oxygen or 2 liters of oxygen and the saturation is about 100% and the appearance of the pneumothorax with a long point is just in 3 centimeters laterally from parasternal positioning. So that's not harmful. You don't really know the distension from anterior to posteriorly, but you have to assume it by clinical thinking, if this might be a big pneumothorax or a small pneumothorax, and the ability and the clinical appearance of the patient, how he talks, how he speaks, and how the saturation behaves with and without additional oxygen leads us to a diagnosis together with an ultrasound. We're doing about 2 hours later to just look if it is more expanded or lower expanded, just stay stationary with a good clinical picture. Then we don't do an X-ray anymore.
Okay.
Okay. In which patients do we have a limit in diagnosing, Rüdiger?
That's
coming to the next
a good
slide.
question, because we've got a very good method, but we also have to know the limitations of this method, and so to know the pitfalls. And look at this CT scan here. You've got a medium-sized pneumothorax, but you also, secondary to the trauma, you've got an emphysema of the chest wall. And if you put a probe onto this position right now, the sound can travel to the pleural line. So quite obviously, you only can diagnose a pneumothorax or rule it out when the sound gets to the pleura. If not, there is no point diagnosing. But the ultrasound image would look kind of the same, because you've got the same reflection from the chest wall conduction velocity of sound, 1540, to air in the emphysema of the chest wall. So it would kind of look like pneumothorax, but you have no window. So this is the reason why the sensitivity and specificity of ultrasound is not 100%, because we still have cases we need all the other methods of imaging. So in doubt, of course, you go for what you're used to do. And of course, a trauma patient gets a CT scan anyway. That's normal. But keep in mind that the method has some limitations, like this one here. Okay, so you may have in your facility or in your country, you may have checklists when to how to use ultrasound, or what to do if you want to rule out pneumothorax after central venous line, for instance. And we are used to doing chest X-rays and to rule out pneumothorax after a subclavian line, for instance. But of course, if it's only a small one, there is no point doing a chest X-ray unless you want to also control the position of the catheter. So like as a practical idea, it is enough after the procedure to rule out pneumothorax by ultrasound. And of course, in case of clinical deterioration, you would scan again. And if you then detect a pneumothorax, you look for lung point in order to get an idea on how large it is. But then you for sure also need X-ray to see whether it is really a big one. And together with the clinical picture, you decide whether or not to put a drain in or not, or just wait and do controls. And so we have checklists also for how to use it in the workup of shortness of breath. This is not for you to read fully right now. We have got it in one of the books we wrote, and of course this is available on our in our web shop, but unfortunately this has been translated only into English and Polish, so it is not available in China yet. So you may have your own checklist in your facilities. So Wolf, what is...
Let's come to the patients, to probably the intensive care unit. So think of a patient that is having a pneumonia, and you don't distinguish a specific bacteria or virus for the pneumonic disease. And you have just a small amount of effusion. And you, with that, if you only have blood culturing that is negative, and you have a small pleural effusion, with ultrasound, you have really an easy and very safe way to do an intervention and to drain the fluid. And going to the next picture, what you have to do, if you go with the abdominal probe, you start with 15 centimeters of depth. So if you want to do an intervention, you have to reduce the depth to about 5 centimeters, or you can use the linear probe. So if you use the linear probe, you can straight go just centimeters or millimeters above the diaphragm. And even if you have the appearance of a compression atelectasis, you can put in the needle safely and look how close. The needle and the catheter is actually kissing the diaphragm, and it's a safe procedure where you can get a good diagnosing tool of microbiologic specificity of pneumonic diagnosis that you don't get in blood culturing or with a sputum or tracheal secrets that are negatively for 1 or 2 weeks in a very, very harmful pneumonia with RDS. So you're doing safe procedures, and what we do promote is not just like it is mostly done, that's what people say in our workshops. In the workshops, they say, oh, they mostly do a scan. They look at the chest wall where the best collection of fluid is. They put away the probe and they insert blindly the needle. But we had, nevertheless, we had pneumothoraxes appearing from evacuating pleural fluids. And this is not necessary. You can do safe procedures. The needles are smaller. You have Seldingers set. And you can even use needles with another surface that is ultrasound friendly, that you can visualize the needle better than an image you saw before. With a tool of many ultrasound manufacturers, you see a diagonal line in the picture. On the right side of that line, you're visualizing the drain easily. And on the left side, it is about invisible. And that's that's a technical issue with the piezo crystals or the apertures. As we said before, we've done some physical information. They don't just send the beam directly, but can also in every impulse send directly and 10 or 20 and 30 degrees to one and to other side to have an optimization of the picture. And if you say to the probe, do mostly put the beam in lines to the right down side, you have an angle of 90 degrees between ultrasound beam and the needle, or here in the picture, the catheter. And on the right side, where you have all the lines going obliquely, you have a good visualization of the drain. And on the left side, with just a straight beam going through, you have, as in a needle with a steer angle, very, very bad imaging of interventional materials.
Thank you. So that was quite in depth, Wolf. I doubt that everyone would be able to recall this all in detail. So looking at our timeline, I think it will be good to to summarize what the take-home messages are. So we have an ultrasound method, bedside, point-of-care ultrasound, with some standard scanning windows, some standard machine working moduses like M mode and B mode, and the color modus. And we have patients with pneumothorax. We can diagnose diseases like in consolidation, where we can see something in the lung where we shouldn't be able to see something, because normally there is only air, but in this case there is blood or whatever, and then all over a sudden we can see something which shouldn't be there under normal conditions. So we're very happy to now go over to the Q&A thing. So Jesse, what do you have?
Yes, we have questions from audience. Can you check from the screen about question, because it's quite long?
I will stop my screen sharing now, so we both can actually look at the.
So I looked at the questions, and probably I can summarize. We have 2 questions appearing, and the first, Marco, he said, well, in cases of coronary pneumonia or a B-line picture with pneumonia and critical illness, you have lung injury and problems. And the question is, in patients with a coronary pneumonia, can anticholinergic drugs play a role in improving lung injury and correcting hypoxia? And my first answer is, in my opinion, no, because this is drying out the lung, and drying out the lung, you mostly have more problems with the secrets coming out of the lung. We are using anticholinergic drugs very seldomly, and I'll tell you in what cases. Well, if you have a case having a patient with an apoplex situation, or I remember a young girl with 14 years, multiple cerebral diseases that is very, very impaired, and lying 24 hours in bed, nearly and harmfully injured with pneumonia 1 or 2 times a year, going to intubation and extubation. And extubating patients that have problems with the swallowing act, and they have a hypersecretion, and you want to avoid re-intubation. We use anticholinergic drugs together with side positioning of the patient, or in the case of the girl, we had about nearly lying prone position and extubating with the help of anticholinergic drugs. That was a way to really be helpful with this medication, that usually in pneumonia, we don't use anticholinergic drugs to improve a lung injury picture or correcting hypoxia. What do you think, Rüdiger?
Well, I'm just having trouble to get like the key point of what we just said. So to
that was no ultrasound question.
Yeah,
that was a clinical question. They are just testing us. Are they just ultrasonographers that are clinically bad? So we have to give an answer.
Well, there is an issue whether we also are intensivists, right? And I can say from my side, look, I'm focusing on outpatient cases, so you are here with the ICU patients. And the second question is again something that is related to the pandemic at the moment. So someone is asking, like, that we have severe pneumonia and serious complications with acute respiratory distress syndrome. And the question is, for patients undergoing a new coronary pneumonia surgery, what interventions are available in perioperative management to promote the treatment of such patients? So this is a very wide question that goes...
Shall I answer?
Please don't. That goes kind of far beyond like the ultrasound issue we have. So it's more like on how the treatment is in general in ARDS. And so our idea is, first of all, to use a method on how to diagnose, to collect all the phenomena you get with patients. So we would like to encourage you to use the ultrasound even on COVID patients in an isolation room. So you kind of wrap the ultrasound machine so that it's hygienically clean. Like in Europe, the treatment procedure nowadays is that we refrain from having chest X-rays every day in the severe ICU patients because it has no consequence. We refrain on doing chest CT scans every so often because no consequence. So we use the much less invasive diagnostic procedure of ultrasound. We just put the probe on, and then we do not have to transport the patient. So that's actually quite good. And then you have got the clinical course, and then you go with the protocol your facility, your country have to deal with severely sick patients.
So there was raised another question, a third question. The question is, can you go over to scan the diaphragm, especially the left side? So if we go back to picture, which picture? Where do we have a scan of diaphragm scanning? No surface.
I'll try and get it.
Well, you're looking for the picture, and I probably start to say some words. Well, how to scan the diaphragm? So you use position of the fast scanning. So the trauma scanning you do, you have to use the abdominal or the curved probe. You align the probe to the chest wall. And mostly important is, if we go with a probe, we, on the right side, look through the window of a parenchymatic organ, and that's the liver. We're going easily through the liver because we align the probe somewhere, and you look through the liver, you look under the diaphragm for some fluid, and you reach even also other organs. But on the left side, as you ask, you always go with a longitudinal scanning. On the right side, very easily, you scan the positioning where you assume that you have the sectioning of the thorax and the abdomen, respectively the liver. And if you find the liver, you put the probe obliquely with the cranial point of the probe going about 30 degrees rotated in the intercostal space, that you don't have any blocking of the view by the bones. Rüdiger, you want to say something?
Well, the advantage of the webinar is that we can discuss it with someone who's very far away. The disadvantage is that we can't just present it like in normal ultrasound courses and just do an exercise. So in an exercise, it would be quite easy to answer this question and how to hold the probe and how to focus on the diaphragm to get a good result that you can actually use for your diagnosis. And of course, it's more difficult on the left side because the spleen is smaller, because you sometimes have air in the stomach, for instance, especially in ICU patients with gastric reflux, for instance. So it is difficult to get the right scanning window, but still it's possible. And then you just scan the diaphragm, use your methods of, is there a dirty curtain? Or do you get in MO, do you get like the regular pattern of a diaphragmatic movement? Even in ventilated patient, you can make use of it, because in a mechanically ventilated patient, of course, you have no diaphragmatic innervation, but you can still see a dirty curtain. The problem is that having a PEEP of whatever, 8 to 10, then the diaphragmatic cupula is very flat and the scanning window gets very, very small. But whenever you have got a spontaneously breathing patient on the machine, you get diaphragmatic innervation, and then it's much easier to see. So do we have any other questions, Wolf?
No.
Okay. Okay. Thank you very much, Dr. Anhab and Dr. Ambuster, and presentation, and helped us many questions in detail professionally. Thank you. And meanwhile, thanks all audience for joining us. For more information, please subscribe and follow Ysonic official account on Facebook, LinkedIn, YouTube, or other medias to turn with us. Thank you, and we'll see you next time.
Thank you very much, and stay healthy. All the best to everyone. Bye-bye.
It was a pleasure to be with you.